Okay, so my pathology that I had is osteoporosis. Oh, I just made the background black just so it's not as distracting, I guess. I hope that's okay. But so pathology is osteoporosis. This is something that is very, very common amongst people worldwide. In the clinic setting, I saw many patients with osteoporosis, but it not being one of the main diagnoses in their treatment. So it's something that's, crucial, but something that it can be helped with some weight bearing and strengthening exercises, but also with some supplemental intake, medications, really, and yeah. So definition, osteoporosis is a condition resulting in a lower than normal bone mass density defined as type 1 or type 2. The less severe form is known as osteopenia. If you like the picture below, we've got some examples here. And the top left is normal bone. The next one to it is osteopenia. You can see that those dots are getting more, they're bigger and it's getting more porous. And then we go down to osteoporosis. It's more of like a honeycomb look almost to the bones. And then we've got severe osteoporosis. So type 1 normally or primarily affects postmenopausal women and is most damaging to the trabecular and cortical bone. Type 2 is more age-related and affects both sexes over the age of 60, but it is known as the silent disease because it doesn't present symptoms until somebody breaks a bone. At that point, it has already done most of its damage. So looking at somebody, you can't be like, you have osteoporosis. So you have to get scans and some other stuff that we'll kind of talk about later. So some etiology. The most common cause in gonadal steroid deficiency, corticosteroid, but also glucocorticoid use, immobilization, whether that be from surgery and you're bedridden for a long time or just not very active and stays in bed a lot, alcohol abuse, smoking, calcium deficiency, and vitamin D deficiency. So osteoporosis is the most common disorder of the skeletal system, occurring mostly in elderly populations, meaning literally an increased porosity of the bone, which kind of, those pictures that we showed last time is what that looks like. This is to say that it refers to a decrease in the hard portions of bone substance in favor of a relative increase in the soft portions. It is commonly recognized as the end result of loss in mass of the bones, ordinarily without any change in their volume or external configuration until pressures from without bring about collapse the structures, weakening from within. So some diagnostic tests. These are your typical ones for osteoporosis. Osteoporosis is identifiable using a bone density scan, such as a DEXA scan, which uses X-rays. So that first picture there on the left is what to expect during a DEXA test. One, you lie on your back on the table, allowing the X-ray to penetrate. Number two, this is more for patient comfort. Legs are going to be propped up onto a padded box of some sort, and then lastly, images are going to be taken of the spine and hip. The one on the picture on the right is what is called T-score. So you'll get a T-score back, and it's going to kind of put you in this range here. So 0, normal bone, up to a -1. So -1, 0 to -1 is about normal. So when osteopenia starts to happen, your score is going to be a -1 to a -2.5. And then osteoporosis is going to be anything greater than a negative 2.5 and above. And then obviously severe osteoporosis is going to have a higher T-score. Some risk factors, advanced age, previous fractures, steroid medication like we talked about, and also prednisone. Parental history of hip fractures is a really big one. Some patients will kind of overlook that in their families. Maybe they just kind of think that their balance is just wonky, but having that knowledge of parental history of hip fractures is something to keep in mind. Low body weight, bad posture is one, so having a real kyphotic posture is going to put more stress on the vertebral bodies, which will be more prone to vertebral fractures, which we'll kind of talk more about that later. And then having a low body weight, but also a high body weight is also two things that could be risk factors. Also currently smoking and excessive alcohol. So age and gender effect. Risk of fracture increases with age in both women and men. Osteoporosis is more likely to occur in women and is still an issue for men as they age, but is often overlooked and therefore untreated. Women often have more accelerated bone loss due to abrupt decline in estrogen during menopause, whereas bone loss in men is a slower process. Peak incidence and fractures occur later in life for men than for women. Some signs and symptoms. Osteoporosis is often a disease with no observable symptoms, like I kind of said before. You can't really just look at somebody and be like, oh yeah, you have osteoporosis. No, you have to get a scan and a T-score and kind of go from there. Patients with osteoporosis typically do not show clinical manifestations of the disease until a fracture occurs. That is also one thing in the research that I saw, that most patients don't even know that they have osteoporosis until they have a fracture, and then they do x-rays, then they can tell that the bone is real porous and weak and brittle. Fractures caused by osteoporosis are called osteoporotic fractures, which occur as a result of low bone mineral density and are triggered by a trauma or a fall, such as a fall. Some patients may experience loss of height or a forward curvature of the upper spine, also known as kyphosis, which is that forward posture. Timing and onset. Osteoporosis most often presents in men and women at least age of 65. Excuse me. Okay. Women are 5 times more likely than men to develop the disease, but men are more likely to develop the disease after the age of 75. Adults reach peak bone mass by age 35, after which bone density declines until the age of 50, and about 1% on average per year. So because estrogen plays a role in bone development, menopausal women are more likely to develop osteoporosis than men. Celiac disease patients are also at an increased risk for osteoporosis due to the malabsorption of nutrients, including calcium and vitamin D. There's a couple other pathologies that kind of play the same factor too. Screening, kind of like we said before, DEXA scans. Normally all women over age of 65 and all men over 70. Postmenopausal women from the ages of 60 to 65 are screened if they have experienced one or more of the following: a fracture after the age of 45, tobacco abuse, a low BMI less than 22, but also a high BMI, and then extended glucocorticoid and corticosteroid use more than 3 months. So corticosteroids is a big thing in physical therapy. Most people get that for, pain and inflammation, but also it's just a really big thing that is kind of like an alternative to surgery in a way, just so it kind of helps with the pain until they absolutely need to get surgery. So, risk of untreatment. So, there are going to be people out there who are stubborn and just don't like going to the doctor and or working on themselves. So, but here are some risks for untreatment. Loss of bone density to the point to where it's dangerous. Falls, preventing falls is going to be a really big factor in kind of getting your bones stronger. Osteoporotic fractures, increased likelihood of death in elderly people who experience a serious fracture from osteoporosis, such as a hip fracture. I've heard many people tell me that when elderly people get hip fractures, it's really hard for them to kind of bounce back. And osteoporosis will not go away without treatment. This disease will only progress if interventions are not undertaken. So, granted, when you start either doing physical therapy or some sort of exercise and supplemental intake and pharmaceuticals and all that stuff, it's going to be a slow process to kind of build up those brittle bones again. But it is something to kind of think about and also keep in. Having good patient education is going to be a really big thing with this process too. So some common complications. Over 200 million people suffer from osteoporosis worldwide. As I said, it's a very common thing. Most people have it, probably a lot of people that you even know have it. Some red flags: in men, low testosterone and low estradiol over the age of 65. In women, low sex hormone and estrogen positive breast cancer patients who take aromatase inhibitor. I thought that was really interesting. But some life crisis would be decreased mobility, hip and spinal fracture, kyphosis, that arching back, which is that picture there, and what we kind of talked about last time. So having that kyphotic posture is going to put so much stress on those anterior aspects of the vertebral bodies. It's just going to be so much, and it's very prone to fractures. And then death. Risk of death increases after hip fractures occur. Some prevention is eat a well-balanced diet and consider supplementation when necessary, mostly calcium, vitamin D. Exercise daily and include strength training at least 2 times per week. Now, that's kind of just on the average that I saw with my research comparing 2 times a week, but obviously as PTs we can't determine that, but it's really at least 2 times a week. Exercise prevents or reverses bone loss by almost 1% per year. And then another prevention, posture. Posture, obviously, with that kyphotic posture, and really even muscle pain. So even having a good posture is going to help with both of those. If you use tobacco, stop. If you drink alcohol, limit to 2 drinks a week or less, as both interfere with calcium absorption. So kind of abusing those things is going to really put you at risk for osteoporosis. Another thing is limiting your caffeine intake to less than 250 milligrams a day. Elderly people always got to have their coffee. So normally keeping a log, or at least knowing how many or how much caffeine is in it, is really good to know, and kind of go from that, or even try switching to decaf coffee, something without caffeine. And then the last thing here is focusing on fall prevention programs. Now this could be, from your doctor or from physical therapy. This could be where we put our knowledge. Common interventions. So as I said before, fall prevention programs is going to be something that is going to be really important. adequate intake of calcium, vitamin D, whether that be from pharmaceuticals or supplements, and then regular weight-bearing exercise. And we'll kind of go into more detail with some exercises later on. Another thing is tobacco discontinuation and minimal alcohol intake. And lastly is maintain a healthy BMI. Being either underweight or overweight can increase your risk for osteoporosis. As I kind of mentioned before, being underweight is going to make those bones brittle. Overweight is going to put lots of stress on your bones, which then causes osteoporosis and more or less osteoporotic fractures as well. So some pharmacology, as I was looking into the pharmacology aspect in osteoporosis, nothing really kind of would affect physical therapy treatment, I should say. Medications such as hormone replacement therapy, calcitonin, and also bisophosphonates, which require adequate calcium and vitamin D intake before and during therapy, which I thought during therapy was kind of interesting. But these also limit the loss of bone mass, deterioration of bone, and increased fracture risk that naturally occurs with aging. So, loss of bone mass and density is going to be most common in everybody with aging. So some supplemental forms could be calcium carbonate, which is something that is more commonly available and is inexpensive and convenient. It's just something you can go to your local drugstore. Another one is calcium citrate, which I found to be a little bit more expensive, but better for adults because it is absorbed well. Other forms include calcium lactate and gluconate, but also vitamin B2 and B3 are good for bone health, and also sunlight. Skin makes vitamin D from UVB rays, can store the vitamin and use it for later. I thought that was really interesting too. I mean, you'd think, yeah, going out into the sunlight, it feels nice and the heat and all that stuff, but it also helps with vitamin D. Other nutritional recommendations, magnesium. 60% total magnesium is stored in bone, necessary for utilization of calcium, which then would increase absorption of calcium into the bone from the blood. Magnesium is found in leafy greens, yogurt, pumpkin seeds, and mini beans, also quinoa. Phosphorus is second most abundant mineral in the body. Adequate intake is essential for bone building during growth. 85% is found in bones and teeth and works with calcium to strengthen bones. This is also found in scallops, meat, poultry, sardines, soybeans, pumpkin seeds, mushrooms, lentils, fish, eggs, and dairy. Vitamin A. Vitamin A deficiency causes bone abnormalities due to impaired osteoclastic and osteoblastic activity, which those are some words that are really good to know. And we'll kind of go into more detail later about that. But however, studies show that high vitamin A intake is in excess of 5,000 IU per day may increase the risk of osteoporosis and hip fractures. Vitamin K is another nutritional recommendation. K1 functions as a cofactor that affects calcium binding. 4 vitamin K dependent proteins have been identified, but observational evidence shows that diets rich in vitamin K is associated with decreased risk of hip fractures in men and women, and then the improvement of bone mineral density. Vitamin K2, 45 milligrams a day, is used in Japan to treat osteoporosis. I thought that was something that was really cool, so I put that in there. But so main takeaway for pharmaceuticals and stuff: vitamin D and calcium. So calcium, Calcium. Calcium is critical for preventing bone disease, including osteoporosis. It is a major building block of bone tissue. Bones are made from collagen and non-collagen proteins and therefore are fortified with calcium. Skeleton is home to about 99% of the body's calcium. If a person doesn't eat enough calcium, the body takes it from the bones, yielding loss of mass and strength. Calcium in our bones also acts as a reservoir for maintaining proper calcium levels in the body, which is critical for healthy nerves and muscles. Our calcium needs vary depending on our life stage. As a kid, your parents have always said, drink your milk, build healthy, strong bones. It's a true thing. But our calcium needs kind of vary depending on our life stage, but elderly, 65 above, menopausal women are more at risk and should implement more calcium into their diets. But the last thing is the ability to absorb calcium decreases with age, which is why seniors need more. Medications that cause osteoporosis. Now this was just kind of a short list. This was just some of the lists that I took in here and I thought were really kind of interesting. Glucocorticoids and corticosteroids, as mentioned before, but with the usage of more than 3 months. Immunosuppressants, heparin and coumadin, anticonvulsants such as gabapentin, opioids, lithium, and excessive thyroid medications. I thought that one was really kind of interesting. Now, obviously, this isn't the whole list, but definitely isn't the least. But with medications, there's always going to have some side effects and stuff. But these were just the main ones that kind of had side effect of developing osteoporosis. So, physical therapy aspect of this kind of pathology is exercise. So 30 minutes of weight-bearing exercise, 5 to 7 days weekly, also strength training. Trying to exercise with the greatest impact that you are able to, and then muscle and bone work together, so therefore strong muscles build stronger bone. So some weight-bearing exercises that we could use. Low impact would be walking, using the elliptical, low impact aerobics, stair stepper, and I also found that Tai Chi, obviously it's good for balance because it's very slow kind of movements, but it's also weight bearing, so I thought that was really something good that you could implement there. Some high impact things would be jogging, running, aerobic dancing, hiking, jumping rope, stair climbing. Those are some high impact things. So some things that are non-weight bearing is biking and swimming, which are non-weight bearing exercises. So swimming or aquatic therapy is good for pain, but it's not going to help with the formation of more bone because of the buoyancies, making it non-weight bearing. So some weight bearing exercises, any exercise that works against the force of gravity, impacts and signals to the bone, stimulating osteoblasts, which then will build more bone tissue. So osteoblast is obviously there to produce more bone tissue, and osteoclast is what kind of rejuvenates bones. It's what breaks it down in order for osteoblast to take effect. So some types of exercises, as said before: walking, hiking, jogging, climbing stairs, playing tennis, and dancing. Now some other weight-bearing exercises that were kind of more simple to do at home rather than like walking and all that other stuff. These were just some quick 5 ones that I used from Marshfield Clinic. Squats, single leg stance with support, sit to stands, step ups, and forward lunge. Now, depending on age and activity level, you can obviously adjust it, but mostly balancing stuff is a main focus, and then strength and weight bearing exercises. Some things to keep in mind is avoiding forward spine flexion. So as I said before, it's that very kyphotic posture is really, really going to put stress onto those vertebral bodies, which is more prone to spinal fractures. In conclusion, really is extremely common worldwide. As I said before, in my clinicals, I've had many, many patients with osteoporosis as a diagnosis, but not so much the main factor. So it's also something that you kind of wanted to implement into their exercises to kind of help with that too, but also helping with their main diagnosis. So it kind of works, you know. Implementing good posture and weight bearing exercises, but also patient education is important. Educating the patient on all of those risk factors can be very detrimental. And then those signs and symptoms is really something to put into perspective of the patient, you know, getting them mindful of those things. You know, some people who fall just think, oh, I'm just clumsy, which could be a factor, but it also could factor in that your bones are just brittle and weak. So, you know, having those pharmaceuticals and those DEXA scans is some clarification for some patients to really realize that it's something that's happening. And then taking action with weight-bearing exercises and supplemental intake and diet. So, you know, weight-bearing exercises, supplemental intake, pharmaceuticals, and diet. So, diet is really a main thing. If patients really aren't into taking medications, I've had some patients who are like that, who really just don't like to take any pain medications or really any medications at all. So my CI would kind of tell them that taking supplements for that can kind of help, but also keeping in mind, you know, telling your doctor about that as well and making sure that that's okay. But those supplements is really going to help too, and also having a healthy diet. But I hope I have broadened your knowledge a little bit of osteoporosis. It's a very common thing, and it's going to be a very common thing. It's just something that kind of happens with old age, menopausal women, which is just the way of life. And then here are my sources. Thank you.